oral fecal as far as transmission goes. Most commonly, well, it's frequently caused from uh, uh, inadequate hand washing of people preparing food for other people. But there's another way that people get it. Does anybody know the population that gets Hep A more than anybody? Homeless IV drug users. It tends to be outbreaks of Hep A in that patient population for whatever reason. I'm sure there's a very good reason, oral fecal transmission and inadequate hygiene. But the classic presentation for people that aren't homeless is eating at a restaurant where somebody didn't wash their hands and acquired it. So contaminated drinking water. It can survive on unwashed hands for up to 4 hours, which is why it's the Department of Health's favorite thing to track down. You can get vaccinated for Hep A, and if you're going to anywhere that's high risk, you can get the vaccine and not worry about it. In general, it causes for most people a mild hepatitis. Their liver enzymes go up. Occasionally, you can get a little jaundice, but that's rare. Usually, they're just sick. Generalized nausea, fever, abdominal pain, dark urine, which is basically dark urine, scleral icterus, jaundice. They're all the same process, which is your bilirubin goes up because your liver is inflamed, not not transporting bile in the appropriate manner, and so things back up, and you get hyperbilirubinemia, which is yellow. So it generally resolves on its own within a few weeks, and most patients that are not immunosuppressed do fine. Hep B is bloodborne. You know that. Also can cause, there's a range of diseases that Hep B can cause, ranging from very mild to fulminant hepatitis, which causes liver failure and death. It's transmitted, it's a bloodborne pathogen, also present, it's transmitted sexually. This is the one that would, it's really not transmitted in saliva. It can occur, transmission has happened anywhere there's sort of bloodborne processes. These days, we're pretty careful about it. With tattooing in general, to be a licensed place, you change needles, obviously. As a result, transmission that way is pretty low. So it's really bloodborne, IV drug use, inadvertent exposure, and sexual transmission. The hepatitis viri, are much, much smaller than HIV. And as a result, transmission of hepatitis is far easier than HIV, as far talking about transmission rates and risks. In general, I forget the Hep B. When we talk about Hep C, it's a pretty small virus compared to HIV, and the transmission rates can be up to 50% when there's an exposure in somebody with an adequate viral load to transmit. Whereas HIV, it's much smaller and the rates are much lower. As far as Hep B goes, the range of illness, well, you can get fulminant disease. Most people have a mild to moderate regular illness. Some patients get hepatitis, recover, and then have antibodies against hepatitis forever and completely get rid of the virus in their body. Some people get the infection, they have a regular course of infection, and then they never actually get rid of the virus, and they become what we call chronic carriers. And those patients, depending on their viral load, can transmit the infection. Some people have, there's a huge variety. Some people are chronic carriers, but they have very little virus in their body, and as a result, they really rarely transmit it and rarely end up with disease processes from the chronic inflammation that hepatitis can cause. Chronic hepatitis B carriers with high viral loads are at risk of chronic inflammation in the liver, which can result in liver cancer. That is far more common when we talk about Hep C. Hep B is stable on environmental surfaces, even with dry blood for 7 days. That's why it's really important to decontaminate things, even if it's all dried up. I don't remember this slide. I'm demonstrating the household contacts and other children who live in it. So that just means that some kids can get exposed, can get it from other family members. It's not that easy to get in that regard. I'm kind of surprised, but I guess that is the case. You do have protective immunity if you clear the antigen. And then here they say probability of infection following exposure is 2% to 40%. I think it's closer to the lower number for the most part. In general, patients that get acute Hep B have a similar presentation, fever, jaundice, hepatomegaly, abdominal pain as a result, general malaise, and very few people become, get fulminant hepatitis from Hep B, where they get acutely ill and die, or need a liver transplant. It's pretty rare, and 5% of infected individuals become chronic carriers. Most patients that have chronic Hep B carriers acquire it via placenta. Basically they get it from their mom during childbirth. 20 to 30% of chronic carriers can ultimately develop cirrhosis or liver cancer. So that's when you have higher viral loads over the course of a lifetime, causing chronic inflammation of the liver, which can get increased risk of cancer. So just another, there's a vaccine, and you should get it if you're working in healthcare, because you never know when you're going to get stuck with a needle, and the chance of getting HIV is far lower than the chance of getting Hep B if somebody is actively infected or has a high viral load of Hep B and stuck with a needle. It's way higher than the 0.25%. For the vaccine, it's 3 shots if you haven't had it. These days, I think they give it to everybody, your first year of life. And so most people that are younger tend to be immune from being vaccinated, but that immunity can wane over time. I had to get an extra Hep B shot a few years ago, and I wasn't immune anymore.
When you have to submit different vaccines, is that on here?
Yeah, that's why you have the titer strong card.
Yeah, you can sign a refusal for Hep B, like at most places. They don't mandate it, like you don't want it. I'm a vaccine. I'm very pro-vaccine. So Hep C. Hep C is very common amongst IV drug users. It's very easily transmitted via bloodborne. So anybody sharing needles, high risk. A lot of the IV drug users that we see clinically have Hep C, like most of them, if they're sort of uncontrolled. It can survive for up to 16 hours on surfaces if it's not clean, but it's really a bloodborne disease for the most part. Ultimately, people that get Hep C, the acute infection is really nothing. I don't think most people are asymptomatic or minimally symptomatic. The problem with Hep C is untreated over the period of their life, they have chronic inflammation of their liver, and then they ultimately develop cirrhosis and/or liver cancer, and that's the risk. The good news about Hep C is we have a treatment now. So patients that are diagnosed in a timely manner before they end up developing cirrhosis can get treated, and it's curative as long as they're not getting themselves Hep C. It is a very, it's like an 8-week course of therapy. It's very expensive, but these days they're finally making a dent in Hep C as a result. The biggest thing about Hep C is because most of the time the transmission is asymptomatic, people don't know they have it until they get tested for it. And so they recommend screening for it now, just as a general thing if you're older, just to make sure. Of course, the problem with the screening is there are false positives. My mom randomly had a screening for Hep, she had lab work done, and they were like, "Oh, just check," and she had tested positive for Hep C. She's flipping out, and ultimately you do an RNA test to confirm it. So after hearing about Hep C for a week straight, Hep C. And then there's other hepatitis. I like using that word. Almost as good as dickhead. So Hep D. Hep D is delta hepatitis is a co-infection, so you can't really have Hep D without having Hep B at the same time. The two go kind of in tandem. I don't think that's something that's very common in the U.S. I really haven't seen any of it, but really just read about it. Hep E is a foodborne, oral fecal transmission. And the big thing to know about Hep E is pregnant women that get Hep E are at increased risk of fulminant disease. So non-A, B, C have all the other hepatitis, and they keep finding more hepatitis viruses. I feel like when I started, we stopped at E, and now
it's
it's
like
more.
G.
Yeah. So, effectively, once again, this is all about not getting stuck with needles and washing your hands. TB. So TB is a tricky disease caused by Mycobacterium tuberculosis. They say that TB is like the great imitator. If you've heard that, that's like the thing about TB. It's very tricky. We're kind of hidden from it because it's far more prevalent outside the U.S. and in third world countries. But previously in the U.S. and in other places, it oftentimes presents looking like other things, which is why they call it. Patients get misdiagnosed for some time before, unless they have plain old pulmonary TB. The problem with TB is it basically causes a small latent infection. There's an acute infectious period, and then untreated, it kind of spreads and it can manifest in other parts of the body with like now that the pulmonary symptoms have gone to the point where I've heard of cases where they did spine surgery on people for osteomyelitis, and they're taking the pus out of somebody's spine so they don't get paralyzed, and then inadvertently everybody in the OR got exposed to TB because it was actually TB causing the infection. Classic weird story about TB. But TB can present in many other ways. But the initial infection is almost always the same because the primary transmission is via respiratory particles. And this is the other infection that you need to wear an N95 mask for. It's the original N95 mask infection. The only reason we ever carried them before COVID. And so maybe Ebola, but how often do you wear this? TB, there's a primary infection with TB, which presents like a very common, like pneumonia-like picture, although it tends to be more indolent and slow going. So weeks of symptoms, cough, fever, night sweats, hemoptysis are all kind of like red flag symptoms for primary TB infection or secondary TB infection. And then ultimately what happens is the patients get through the primary period, and then they can have secondary TB in their lungs, which oftentimes causes upper lobe infections. And so whenever you're looking at a chest x-ray and you see upper lobe infection, that's kind of like, oh, is this secondary TB? Primary TB can give you regular, it just looks like pneumonia. It would get misdiagnosed usually initially, unless patients had all those other sort of night sweats. Like when people volunteer night sweats and hemoptysis, then like it's kind of like you're giving the diagnosis on you're not testing for it, and it's problematic. But for the most part, without that, it just sounds like any other respiratory infection when it's acute. When it becomes more chronic, then a lot of those signs are more manifested. And then ultimately, if it's out of the lungs and in other parts of the body, you wouldn't know that the person has TB unless you were sort of suspicious or there was some other sort of marketing thing that would say, oh, this is TB. The good news, though, is that really if somebody has disseminated TB or TB in other parts of their body, they're not actively coughing it out. So the communicability of non-pulmonary, extrapulmonary TB is quite low. Unless you're like operating on the person and you use TB. So this is a TB anchor. There are the dermal manifestations of TB that you can see. That looks bad. Somebody had that, I'd be like, cancer. But if they had other prior history that sort of suggested that they could be at risk of TB, that would be sort of a primary lesion. This is miliary TB, I think, or another cutaneous manifestation of TB. Miliary TB is a pattern that you see on the lung. It's airborne droplet. Need to wear an N95 mask. It takes a decent amount of time to get TB. We always worry, and I would worry, I guess, being in the back of an ambulance because you're basically in a closet with somebody. Like it's a small area but it generally takes a prolonged exposure to get it, which is why the risk isn't terrible. So obviously increased, wear a mask, but the for healthcare workers that are not doing like actively managing somebody's airway, the chances are decreased that transient brief exposure would cause you to get it, but certainly could in that sense, and that's why we do everything. Like I said, it's really an indolent infection. We're talking about a 4 to 12 week incubation period, and then once patients are treated, they're generally not communicable after a couple weeks, as long as it's TB that is sensitive to the antibiotics being administered. Problem with TB is there's drug-resistant TB out there, and it's becoming much more prevalent. It used to be just Russia had all the drug-resistant TB. It's kind of throughout the world. So more about primary TB, which is what I was talking about earlier, and then the infection untreated secondary or reactivation TB, and that's when you start to see it in the upper lobes of the lung. And at this point, usually patients have low-grade, ongoing indolent symptoms. Hemoptysis. What's the other thing you want to think about when somebody has hemoptysis? As soon as somebody says hemoptysis, it should be kind of like TB is one thing that pops into your head, unless they're like a smoker or they cough, they choked on something and coughing up blood. But what's another disease state, non-infectious, that presents with hemoptysis occasionally? Well, yeah, but that's more hepatitis. What'd you say?
Lung cancer?
Sure. What's one that kills you quick though? Kills you quick, shortness of breath, little hemoptysis. PE. Always think of PE when the problem with
Dana said
PE.
it first, just so everyone knows. Dana said it first.
Wrong word. PE is one of those.
Only one is good.
In emergency medicine, PE is one of those diagnoses that you don't make unless it's in your head, and so everybody coming in with chest pain or shortness of breath, you don't have to be like, oh, I have to rule out PE in this case, but you have to think of it. Whenever it gets missed, PE gets missed. That's why it's like a tricky diagnosis. I know we're talking about infectious disease.
I just had a patient the other day that had bilateral PEs, like massive ones, and I thought he was stroking out. He was super altered, they had pads on him when we got there, and he was in rough shape. But I kept thinking, where's the blood in his mouth coming from? Because I thought maybe there's some kind of trauma when they were suctioning. But there was still quite a bit, and I obviously didn't see anything. And now that you're saying that, I'm thinking
Yeah, severe massive PE. Those patients will have hemoptysis. Not all the time, but it happens. The only thing I would say to everybody, you can only think with what's in your head, right? If it's not in your head, you're not going to think about it. And PE is one of those diagnoses that you don't see every day. And so it's just sort of everybody having chest pain, you're always thinking ACS, and appropriately so, because ACS is what you want to worry about. It's where the money's at. But it's the second most common life-threatening cause of chest pain and shortness of breath that acutely life-threatening. So if you don't think about it, then you won't think about it no matter. So I tell people you don't have to always look it up, but if you have to consider it. Anyway, I diverged from the primary topic. TB. So important to cover the patient's mouth. Put a mask on them. Put a mask on you. An N95 mask, and recognizing anybody that's potentially at risk, so that there's no further exposures. Meningococcal meningitis. So when we talk about, take away the meningococcal part, just meningitis in general. There's a lot of different types of meningitis. There's viral meningitis, there's bacterial meningitis. Most cases of meningitis in general are viral meningitis, and they get better on their own without a problem. There's other types of you can get Lyme meningitis, which is different type of bacterial meningitis that's more kind of not chronic, but over a long course. The meningitis that we worry about that kills you very quickly is Neisseria meningitis, or meningococcal meningitis. That's the one where the patient wakes up feeling sick and is dead by sundown. You know? Rapidly progressive and dangerous. The most common bacterial cause of meningitis is strep pneumoniae. Streptococcal infections, the person's somewhat immunosuppressed, spreads to the central nervous system, and they get meningitis from it. And that can kill, but usually affects the very old, patients that are affected and immunosuppressed. Haemophilus influenza we vaccinate against, so it doesn't really cause nearly the number of infections that it used to cause. Like I said, most cases are viral and are not really an issue. When we talk about meningitis and infection control plans and notifying you guys when you get exposed, it's really for Neisseria. If we know the patient has strep pneumonia, then we don't worry. And these days, when we do spinal taps on people, we send it for rapid antigens testing, so we can usually get the answer within a few hours. You don't have to wait for the culture to grow. So droplet transmission, nasal or oral secretions. It's useful to know that Neisseria lives in people's nose, like 2 to 10%, I think. Like, I don't think I'm making that up. As a percentage of people that have Neisseria just sitting in their nose. It's the certain invasive strains that occasionally cause an infection, and those aren't present. Nares. Having fun with my plural.
Yes, I can see that.
I'm not normally well. These days we have a vaccine against meningococcal meningitis. Do you guys have to take it for college? Is it required? Yeah. It's probably good. And so the number of cases is gone down. We still get outbreaks like every year. It usually is like midwinter. You find that there's an outbreak in some communal living environment, whether it's a dorm or a jail or something like that.
Irish toll.
400 people living in town. Meningococcal meningitis. So here we go. Oh, look. 2 to 10% of the population may carry meningococci at any one time. But they just hang out and don't actually cause infection. It's when they get an invasive strain that things cause problems where the bacteria change over time to become invasive. You're at high risk if you're directly exposed to secretions. And it's a midwinter illness very commonly. So signs and symptoms, the initial presentation of meningococcemia is really just like every other infection: fever, chills, joint pain, body aches, and then as the sort of meningococci invade the body, you start getting petechial rash, which is like the red flag symptom, petechial rash. How to tell a petechial rash is you push on it, and if it doesn't blanch, that's petechial. If you ever look at somebody that's been forcefully vomiting, they usually have some petechiae under their eyes. Commonly appreciated, but these people have petechial rash elsewhere in their body. So untreated, the disease can rapidly progress. People get neck stiffness, photophobia, classic signs of meningitis. You should know Kernig's and Brudzinski's signs for the test in real life. 10% of patients get septic shock. I think that's higher actually. 10% of patients can get Waterhouse-Friderichsen syndrome, which is when you get adrenal hemorrhage, which causes adrenal insufficiency, which then causes the acute adrenal insufficiency, causes the blood pressure to plummet. So they look at septic shock patients. And then ultimately untreated, you get DIC, coma, and then patients die. So it's a rapidly progressive illness. Fortunately, so pediatric patients 6 months to 2 years are susceptible. Younger than 6 months, it's pretty rare because you have the protective maternal antibodies still floating around in the baby's body. And it's really a tough diagnosis in infants because infants can't talk. So you don't know what's wrong, right? You just know they have a fever and acting right, lethargic. Why we do sepsis workups on young kids frequently when they present with signs and symptoms that are potentially consistent with the diagnosis. The bulging of any bulging fontanelle isn't great. If you have a bulging fontanelle, it's a sign of increased intracranial pressure, and so somebody who has meningitis and has an inflamed central nervous system oftentimes ends up with increased intracranial pressure, and this is the obvious sign that it's increased. Older kids, you're looking for Koenig's and Brudzinski sign, but really you're looking for stiffness of their spinal. So protective measures, it's always the same. Wearing masks and keeping yourself protected from being exposed to secretions. There is prophylaxis, and it's quite efficacious. So that's why we have the whole sort of need to notify agencies, because you really just need one dose of antibiotics and you're at risk or if you've been exposed to the patient. You use a single dose of rifampin or Cipro. Ceftriaxone's a shot, so I'd go for the rifampin. Pneumonia. So pneumonia, it's just a general term, right? Pneumonia just means pus in the lung. And so what can cause pus in the lung? Any type of infection. So there's a zillion different ways that we can present with pneumonia. Kids, viral pneumonia is super common. Basically gets better on its own, whether you treat it or not. Bacterial pneumonia, we treat with antibiotics. And these are the most common bacteria that give you pneumonia. Strep pneumonia, pneumococcus, that's like the classic bug. Got it in the name. Mycoplasma pneumonia. Mycoplasma pneumonia, anybody know what that causes clinically? You heard of like walking pneumonia? It's like this mild, and we had an outbreak of mycoplasma in this area this past winter. So it certainly does happen. Mycoplasma is it's really a low-grade pneumonia. It usually ends up getting diagnosed because the person has like a flu-like illness, the cough, viral symptoms. They're just not getting better. And so now it's like weeks and weeks. And it frequently, untreated, eventually will get better on its own. But if diagnosed, we use a macrolide like Zithromax. Treats typical pneumonias. Legionella is another typical pneumonia presentation. Klebsiella. Anybody know who gets Klebsiella pneumonia? Just trivia. Probably. But alcohol. Not you. I thought you were going, eh? You're pointing at her.
With my look, actually, I would probably look.
So, Klebsiella is most common, it's diagnosed alcoholic, and they get lung abscesses from it. Severe alcoholic, effectively immunosuppressed. So that's the association. So fungal pneumonias are pretty rare, but certainly happen. Rare fungal pneumonias. Is histoplasmosis a fungal pneumonia? Histoplasmosis, like a disease of Appalachia. And then what's the one that what's the guy from Young Frankenstein? He just died. He was in the news. Him and his wife in Arizona.
Oh,
Gene Hackman. So they had what was the disease that they had?
Rats,
Yeah, rat feces, but it causes hantavirus, like pulmonary, not hantavirus, but it causes like a pulmonary syndrome. What was it? Let me Google it. It's killing me. So his wife had it, and so presumably they both died. So he probably had it, or he might have just had dementia, and she died, and then he just died from not having anybody to care for him. Terrible the way we go. Was it hantavirus? And so hantavirus pulmonary syndrome. That I think can't be fungal. So routes of transmission. Really, I mean, these are all droplet spread for the most part. Yeah, you can get bacteria and touch it and get it in your mouth. But most of these are droplet spread. Now, who gets it? patients that are at risk, right? And who's at risk? Immunosuppressed patients, the elderly, the very young. Those are the people that commonly get pneumonia. Mycoplasma pneumonia is kind of interesting because young, healthy people get it. So it's a little atypical in that regard. But your typical lobar pneumonia caused by strep pneumonia is a disease of the very young and the very old. Patients that have compromised pulmonary systems, obviously, for whatever reason, can get pneumonia. And pneumonia is very commonly a secondary infection, right? So you get a viral infection like influenza. And the most common complicated influenza is when the patient gets a super infection like pneumonia on top of a viral infection. They seem to be getting better from their flu, and it's like day 5 or 7, and then they start getting sicker again. Kind of a red flag that something is happening. And usually that's gone on to develop pneumonia. Compromised lungs, people that have a degree of pulmonary edema all the time, it just kind of messes up the works and then interferes with the mucociliary elevator, and as a result, lead to pneumonia. Patients with bad lungs in general. Anybody that aspirates, aspiration pneumonia causes a non-infectious type of pneumonia, but then can junk up the works and put them at risk of having pneumonia. What trauma patients are at risk of pneumonia?
Drowning.
Definitely. There's another one common. Rib fractures. People with multiple rib fractures because it hurts to breathe, right? So they splint their respirations, and then they get like alveolar surfactant, collapse, and they've like localized collapse of the lung, and then it's easy for bacteria to kind of get in there. And that's why we tell people with multiple rib fractures you need to take 10 good deep breaths an hour to kind of prevent that. I don't know about the evidence for this. This is what we learn in medicine. That, one of the things that you learn, you'll find over your career, if you end up working in medicine for the length of your career, is things that seem like you're just taught are always true. Someone finally does a study on, like 10 years later, and you're like, wow, the whole time that was bullshit. So always question. Yeah, exactly. I mean, reptilian. I mean, like all the things we used to do that we don't do, and then some things we do and we stop doing, and then 10 years later they're like, actually, it works. And like as science evolves, so medicine is an evolving science, so things change. But I always wonder if you're ever actually, as an aside, if you're ever wondering about like evidence for stuff, because like we like to think that everything we do is like solidly based in medical evidence, and I can tell you that that's not true. There's a website called thennt.com. That NNT is number needed to treat, and it's like an academic approach to common things that we do in medicine and the evidence for or against those things. It's called thennt.com. If you go to like treatment section, they have it listed by specialty, and it's really interesting. I don't want to dissuade you in your career choice, but one of the things if you go under emergency medicine or critical care medicine is ACLS medications. Do you know how the number needed to treat, like a patient to have a good positive outcome of cardiac arrest with ACLS medications? It's infinity because there's no benefit, and the NNH, the number needed to harm, is really like 0 because the patients are already dead, which is why we keep doing it. And it's not going to hurt anybody. They're already in cardiac arrest, but the benefit of ACLS medications is unfortunately pretty low. So all the other things like CPR, defibrillation, airway management are huge. And so it's not like your jobs are pointless, but the ACLS medications that you have to memorize and know everything about, we start peeling them away one at a time. So the NNT.com is really interesting. I mean, it has stuff like, how we treat ear infections, like everything in medicine. And so looking through it, I'm kind of like, wow. Every time I go look through it, I learn something new. Anyway, thennt.com.
Like Nancy.
Yeah, THENNT.com.
Yeah. I was trying to
Wow.
Wow.
That's great.
Names.
Dana's on a
You put the ENT.com. I got
Did you get it up?
Yeah.
Okay.
D and NT and then E. I put E
Number needed to treat.
Never needed to treat.
Because they keep them.
So, anyway, geriatric patients, like I was saying, very old to very young. So, most cases of pneumonia are completely, like they present like any other infectious disease. Fever, general malaise, viral respiratory symptoms, are oftentimes easily confused. Cough, in general, they're productive of sputum, but not always. And then on chest X-ray, you guys can see, the key to reading an X-ray is looking for asymmetry. So here's a nice normal lung, and you're like, oh, what's that? Huge inflammatory process. Could be a tumor, but probably somebody with a fever and a cough is pneumonia. And then shortness of breath as they get progressively worse. So, how we treat pneumonia? Well, the most important thing is supportive care. Obviously, people aren't breathing adequately if they're hypoxic or respiratory failure, supporting their oxygenation and their ventilation, respectively. There's a zillion different antibiotics that work against your typical bacterial pneumonia. It doesn't usually take anything super complicated. And healthy people, for the most part, don't need to be in the hospital for pneumonia. They're not hypoxic. They actually have pretty good risk-derived scores that you can calculate, to determine how safe it is to discharge somebody with pneumonia. So there are drug-resistant pneumonias, various strains of bacteria that cause, certain sort of worse infections, so to speak. And the type of bacteria causing the pneumonia can oftentimes determine the extent of it. So patients with Klebsiella pneumonia, they get lung abscesses. They get very sick. Patients with MRSA pneumonia get very, very sick. Patients with strep pneumo that are otherwise healthy usually recover. Really, it depends on the bacteria, depends on the patient. Unless patients have either a resistant strain or some type of more dangerous bacterial infection, usually don't need to be in isolation. Tetanus. So, more rare diseases that are kind of important because they're commonly talked about and we commonly deal with preventing them. Common in agriculture areas. Who gets tetanus in the United States more commonly than anybody?
Our kids.
Yeah, close. IV drug abusers. Yeah. IV drug abusers are at increased risk. Oftentimes they're sharing needles, things aren't very hygienic, etc. And so that's the patient population. So this is another vaccine preventable disease. Everybody gets a Tdap, 2 months, 4 months, 6 months, 8 months, 12 months, 8 months, 4 shots. And that prevents tetanus, diphtheria, and then they get a booster at 11 or 12, and then basically everybody forgets about it until they get a cut the rest of their life. And so that's why emergency departments give tetanus shots to everybody, because it's one of these public health service things that we do, because people don't remember the tetanus shot. And when you go to your doctor for a checkup at age 30, they're like, not thinking about tetanus. So that's why tetanus is oftentimes like sort of an ED managed illness, even though we don't see tetanus ever, or very, very rarely. So tetanus, when it happens, is pretty terrible. It's caused by Clostridium tetani. That's the bacteria. And usually gets in through some kind of a wound, which is why IV drug abusers are sort of at increased risk because they tend to be poorly hygienic. A lot of times they have skin wounds, and those skin wounds then get infected. But stepping on a rusty nail, something that's been exposed to a lot of bacteria, the environment for Clostridium tetani is dead or necrotic tissue, and so that's why stepping on a rusty nail, etc., potentially increased risk. And so it's an indication to make sure that you have your tetanus shot up to date. And the disease process, while I've never seen it in my life, but I know people that have. So it does happen. They get ultimately these spasms, severe contractions They, riscus sardonicus, I think is the term. When you get that weird smile from spasms of the facial muscles. And so that's why these pictures of these people having like these spastic episodes. And untreated, ultimately, patients get respiratory failure. Infant tetanus, which is the honey, which is the honey, unpasteurized honey puts patients at increased risk of very young babies at increased risk of tetanus. That's another. Usually, those patients end up floppy. That's like the presentation, like a floppy baby. They have just and they're in they go into respiratory failure untreated. So really, the management is protecting people from getting it by giving them a tetanus shot when they get a wound. If somebody has a high-risk wound, which is not commonly done, but if somebody has a high-risk wound or there's some reason to believe they're really at high risk, then we actually give immune globulin. But that's not very common. Tetanus in general is not very common as an infection. So when we see a greater outbreak, then, people end up getting immune globulin frequently, and then it kind of falls out of favor again. Rabies. So rabies is a pretty interesting infection. We all know rabies virus causes it. Ultimately, the patients get bitten by an animal that the rabies virus is in the saliva, and the bite breaks the skin. And rabies virus enters the body, and it travels via the neurons up the nerve system to get to the brain. And it takes a few weeks to get there, which is fortunate because it offers us an opportunity to intervene in a timely when it's like when the bite has been noted and it's managed in a timely manner. We don't see a lot of rabies in the United States. There's probably a couple cases a year in general. Talking about the entire United States, and that's because the Department of Health actively intervenes with all the bite management that happens. So. I've never heard of airborne spread, but I guess in that case that makes sense. Most of the time, if you're traveling or going to travel somewhere where rabies is super common, they recommend getting a vaccination before you go. In the U.S., rabies, raccoons are the things we worry about here, bats, foxes, dogs. Rabies transmission from a pet dog is quite rare. I think I forget. Someone gave me some statistic that I can't remember, but it's so low that we still worry about it when it's undocumented. And, the initial management for a pet that doesn't have documented rabies immunity is just to watch them. Usually takes them a week to get sick if they're rabid, and if they're having rabies symptoms, then they should get sick and die within a week. And you've got a few weeks to intervene. So the Department of Health usually will just monitor the animal, and if the animal is fine, person. But obviously, wild animals you can't really monitor, and especially since most of the time they get away. If you catch the animal, like you get a bat in your house, you can go get it tested. I had to do that. Bat got in my house. You ever try to catch a bat?
Mm-hmm.
It's hard.
Yeah.
Scary as like.
You know how you do it?
Yeah, I do now after I paid $400 to somebody to do it for me.
Quarters or rocks and throw it up in the air, and they'll think it's something, and they'll catch it. They'll try to catch it, and then close it stuff.
Oh. I was amazed. The guy, so my wife calls me. She's like, "Oh, there's a bat in the house. There's a bat in the house." I'm like, "It's not." My wife is like, total panic about everything. We're gonna die. So there's a bat in the house. I'm like, "Oh, it's in our bedroom." I'm like, "Yeah." So I drive home and I get home and I go into the bedroom. I'm looking around. I'm like. And then all of a sudden this thing, it's like, it's trapped in the bedroom, so it's just flying circles. I was like, ah! I ran out. I was so scared. I was like, I shut the door. I'm like, all right, I gotta get this thing. So then I tried like trapping it with like a laundry basket and this and that. Just kept getting away. So finally, I'm like, you know what? Like, I don't know. The kids, like, there was a question as to whether the kids were in the room. They weren't, but now everybody's recreating history because they're panicking. And so I called the guy. And the wildlife guy comes in and he's like, "Oh, got a bat in the house? All right." Takes an O-ring forceps, which is basically like what we use for OB, like the big long forceps, kind of like a McGill forceps, but straight. So it's not like, just straight with like little loops that close together. And he just walks up, the bat's on the freaking blinds, and he goes, and he just puts it with a wing, and he puts it in a Chinese, dish, Chinese takeout dish, shuts it, and he's like, there you go. And he's like, gives me the bill, $400. It was $350, and he's like, for 50 more, we'll test the animal. And I was like, all right, 400, no rabies. $400. Now I know what
Now
to
you
do
know what to do.
next time. But I did go around my house and seal every. They can get in, like just like mice. They can go through a 1/4 inch. Super easy. Anyway, so rabies. The thing about rabies is we can treat it, and the way we treat it, it's kind of cool, at least to me. Patient has a bite on their extremity that they're at risk of rabies. It takes a couple weeks for it to travel up through the nervous system and cause rabies. So what you do is we have immunoglobulin, which basically blocks or binds the virus as it travels up the nerve. And so you give half of the injection of immunoglobulin around the bite site, and the other half a little higher up, somewhere usually on the upper arm, if it's an extremity, on the upper arm or the anterior thigh if it's the lower extremity. You never inject it in the gluteus, which we had a bunch of people doing that in our hospital, so we got spanked by the Department of Health when we found out. I didn't know either, but essentially we're all fat, and so it doesn't ever get into the muscle when you inject it there. And then when it does, if you inject it too close to the sciatic nerve, it can cause inflammation and problems. So it's a big no. Either the vaccine or the immunoglobulin should go in the wound, but it can go anywhere else. And so we give half at the wound site of the immunoglobulin, half here, and that either blocks the transmission or delays the transmission long enough so that in the other arm you give the vaccine, which takes 2 weeks to kick in. So by the time the virus has sort of gotten through the initial barrier, traveled up the arm, hits the next barrier, if any of it makes it past it, it takes a while for that to happen. At which point, the 2 weeks, the vaccine has now caused an immune reaction, and you're immune. So by the time it hits the brain, the person's actually immune from rabies. It's kind of neat, right?
If you
Exactly.
get the rabies vaccine once, do they give it to you again if you get bit by another animal, or is it kind of like a one and done?
The vaccine is somewhat temporally related, so it wanes over time, and so you oftentimes need another. If you get re-exposed, you need another shot, and I think it's only 2 shots. Don't quote me. If you look it up, it's listed what you need. It's different. You don't need the full series. Yeah,
In the
it's
stomach.
5
Stomach,
shots.
yeah.
It's normally the vaccine is day 0, 2, 7, 21, 4 or 5 shots over a period of a month. The last shot is like day 28. And if you've already had the vaccine at some point, you either need 1 or 2. I forget the exact number. These are things that fortunately we have time to look up before we can I see the patient.
Katie likes to kidnap raccoons.
Stay away from those raccoons. They're crazy.
Trash pandas.
Yeah, she likes her trash
Trash cans. We have a raccoon that lives under our deck that's like
400 pounds.
so big.
Where
It
do
climbs
you
up the
live?
tree. And you're like, yeah, you're welcome to come and take it. Mount Hudson.
You think I won't go to the for a raccoon?
So untreated, rabies causes encephalitis, which almost uniformly ends in death. Although there was somebody that survived rabies a couple years ago. I remember reading news, and so it is theoretically survivable, but most patients don't. And so undiagnosed, it progresses to a general viral sort of syndrome, headache, fever, general malaise, which progresses to delirium. They get masseter problems. There's this hydrophobia sort of classic presentation. I don't know how common that is. And then delirium, altered mental status as they get progressively worsening encephalitis, and then die. So don't get bitten. Wash your hands. And obviously, if somebody's gotten bitten by an at-risk animal, Department of Health is very good about not giving vaccine when it's not an animal that's at risk. I used to think they just always, would just recommend it. Like everybody in New York is very medical legal conscious. They're always afraid of doing it. they're pretty honest. They're like, no, that's not an animal that's at risk. I like their
You know what their at-risk animals are?
so all of these wild, like wild raccoons, bats, most wild animals, but like small rabbits are not at high risk. Chickens, the what are the
Possums.
possums?
Possums are immune.
I thought they were at risk.
Possums are immune.
We just had a case in
They're-
which somebody.
So their body
Look it up.
temperature is too low, so that's why they're not a rabies
They don't get
vector.
it?
So when you look at your wildlife rehab licenses, you have your at-risk ones that you need a type 2 license, and your not at-risk ones that you need a type 1 license for. So the rabies vector carrying are the type 2.
So
Possums
the
aren't those
Possums
type
are
of-
not in there.
Possums
That's
are not in there. In this area, skunks, foxes, raccoons, bears, coyotes,
Chipmunks are not.
bats, chipmunks, squirrels, rabbits.
Squirrels, those are all low
None
risk.
of those are.
Yeah, but there's the one in between. I'm trying to remember. I'll look it up after the break. That I got tricked because I was like, no, I don't think that's high risk, and then the Department of Health sent him back to get it. And I was like, really? And I'll look it up during the break what it was. So yeah, I wouldn't play with a possum.
Yeah.
They're cute.
No, they're not.
Yeah.
They like to sit on my shoulder.
They're just fucking big rats.
There's somebody for everybody. All right, so moving along.
He breaks in my house to eat cat food.
It's just a big
Oh,
rat.
moving along.
Yeah, I mean, you can skip.
Do you want to push on? What do you guys want to do? Show of hands. Stay.
I
Keep
just need a
going.
quick snack.
You need a quick snack and take